Hi, good morning, good afternoon, and good evening to you wherever you are. Welcome to this webinar co-hosted by IPA and Kaijin. We're so happy to have you all here. I'd like to start out by introducing our speaker today, Dr. Wendy Thanassi. Dr. Wendy Thanassi completed college at Yale as a double major in biology and African studies, followed by medical school at Stanford and then back to Yale for emergency medicine specialty training. Over the years, she completed multiple volunteer and research projects in Thailand, Papua New Guinea, Australia, South Africa, and Namibia, among others. Professionally, she worked for the United States Department of Veterans Affairs for 16 years, leading the national testing programs for its 400,000 healthcare workers, and as a professor at Stanford in Medicine and Population Health Services. She sits on CDC's Advisory Council for the Elimination of TB and is the United States representative to the International Congress on Occupational Health, representing all employed Americans. Dr. Thanassi was honored to join the Kaijin team as the Senior Medical Director for Tuberculosis and Infectious Diseases in North America in late January of this year. Thank you so much, Dr. Thanassi, for being here today.
Thank you so much, Alexandra. Terrific. Thank you, Alexandra, and thank you to everyone who, I loved that introduction. Good morning, good afternoon, and good night, since we are a worldwide crew. Personally, I'm coming to you from California. It's early morning, the sun is just rising, so this is a really nice way to start the day. Again, thank you for having me. We're going to be talking today about IGRA, the interferon gamma release assays, and the TB testing implementation. I'm going to give you the second part of the webinar. You saw Dr. Kawamura give part one, where she had a lot of papers and gave you a lot of the reasoning for doing the IGRA testing. I'm here to do a little bit more of the practical implementation and have you really look deep down at the test. And it is a test that I feel very excited about using, and really it's been a part of my life for many years. Let me put this away. So just to start off, you're all aware, you're probably here because you're aware of the CDC's technical instructions, which does say applicants 2 years old and older, examined in countries with a WHO estimated TB incidence of greater than 20 cases per 100,000, must have an interferon gamma release assay. And so that's IGRA, interferon gamma release assay, the whole blood tests. IGRA testing in these countries for applicants over 15 years of age must be implemented by October 1st. So you're here to talk with me about how that's going to go for you. I hope it's going to be smooth, and we at Kaijin will always be here to help you. There we go. Okay, so our discussion plan today will be to start with a perspective on why latent tuberculosis is so important for you to diagnose for these immigrants who are coming to the United States. I know that in your countries, the situation might be very different, but I hope this will help you understand why your role is so important to us. Secondly, we'll talk about the tests, their performance and importance, go over TST a little bit, and then dive down deep into the quantiferon tuberculosis interferon gamma release assay, the whole blood test, the IGRA, and a couple of slides at the end just to put it together in the clinical context. So again, the context, I think you are all around the world. I mentioned that I'm here in California. And so I made this slide a number of years ago. I really like it. It is the incidence of tuberculosis per 100,000 on the y-axis on the far left of the screen. And then across the bottom on the x-axis, you'll see the names of countries. The vertical red lines tell you what the incidence rate is per 100,000 people of tuberculosis. What's really interesting about this slide is that in between each of these lines are other countries. So this represents the world and in all of its glory and in all of its stages of transition. The United States, if you look carefully, is not on the x-axis at all. And if I were live in front of you, I would be asking people in the audience to find it on the x-axis and point to where they think it is. But we'll skip ahead and I'll show you. The United States of America has such a low tuberculosis incidence as to not even register a red bump on this graph. The United States has such a low rate of active tuberculosis as to keep company with island nations like the British Virgin Islands and Iceland and Grenada. So it's an extraordinary public health feat that a country of 300 billion has gone from having tuberculosis as the leading cause of death 100 years ago to where we are now, which is an incidence so low as to barely register. We, of course, still have some tuberculosis. And if you look at those graphs just in the United States over time, you would see that, as I said, 100 years ago, it was the leading cause of death in the United States. And then the line over the last 100 years has just gone steadily down to the right, so that about 30, 40 years ago, the United States incidence was all the way down to 10 cases per 100,000. And then just 2 years ago, at the middle of the pandemic, we had of 300 million people, only 8,000 cases of active TB. Now we've had a couple of, and I would say that we can attribute that, I think, to our public health efforts here. Now, all of your countries are doing wonderful jobs in public health. We just have we have a good situation to start with, being so isolated, but we have clean water and clean air and a lot of space in order to help drive that down. But we do have these episodes where the incidence goes up. One of those was in the early 90s. And again, in person, I would have asked you, why did it go up? Well, it went up because of the HIV epidemic. And then we see another little upward swing right now in the 22 to 23 era, which is because of COVID-19. And you all are very familiar with the resources that we would have used to care for people with TB being repurposed to care for people with COVID-19. The elimination threshold for tuberculosis in the United States would be around 300 cases per 1 million population. So we're still a ways from that, but we're getting close, and you all will be part of this effort to eliminate active TB in the US. So let's look at where tuberculosis is in the US right now. You can see on this slide that about 75% of active TB in the US is in the non-US born. The US born population only carries about 25% of the TB burden. And I will say honestly, a lot of that TB is infection from recent active cases in the original cohort, the non-US born. So we pay a lot of attention to caring for this group, and we're really happy to have you part of this partnership to take care of them as they become Americans. Even though we have so many great public health advantages here in the United States right now, if one develops active TB in the US, the mortality rate remains over 10%. So 10 to 13% or so of people with active TB in the US will die of that disease. And we're obviously all here to prevent that. So let's drill down a little bit more into that blue box. This is 1 year earlier, and this little slide here represents California. But this graphic looks the same in much of the United States. That is, less than 20% of active TB in the US is in the United States born population, and most is in the non-US born, with some countries contributing the most. Where I am in California, that's largely Mexico, we're very grateful to have these workers working our farms and helping us produce the food to support 300 million people. We have the Philippines. A lot of those people come here and are very valued healthcare workers. And then Vietnam, China, India, and Central America round out the cohort. And which of these people who you see who will be coming into the United States who do have latent tuberculosis are more likely to develop active tuberculosis? Well, it's those people who have comorbid diseases. So people who also have other diseases going on in their bodies that weaken their immune systems are more likely to develop active TB. And some of those rates are really extraordinary. So persons who have HIV have 100 times the rate of going from latent TB to active TB compared to people who do not have HIV. And then if you look a little more to the right, if one's had an organ transplant, they're 50 times more likely to develop active TB, and severe kidney disease 25 times more likely. Now, these are people who already have latent TB who you will see coming into the country. So making special note of these comorbid diseases with their TB infection is really important so that when they get here, we can treat them for latent TB and prevent it ever becoming active. So I was very grateful to my colleague who's on this call and available for your questions, Dr. Nikolaevsky, for sharing one of his slides with me about a paper that shows you how your work with the migrants makes a difference to us here in the US. So interferon gamma release assay testing was done in over 368,000 migrants to the UK in 2014 to 2015 in this paper. And the goal was to identify and treat latent TB in the primary care setting. The finding was that LTBI treatment lowered the risk of active TB disease. We understand that, that makes sense. What broke through in this study was that there were 135 active TB cases. All of those were in people who had tested positive by IGRA, so they were knowable. They were a knowable cohort. But of those 135 who developed active TB, only 7 of them were in the diagnosed and treated group for latent TB. 128 of those cases were in the diagnosed but untreated group, which shows us how incredibly important it is for us to make the right diagnosis through you all using the IGRAs, and then for us to follow up and get the treatment so they don't become a statistic in the US. Okay, let's move past demographics and talk about the performance and importance of the tests. I don't want to spend too much time on the TST. I know you all know it, and you probably know it a lot better than I do, but some of the reasons that we've stopped using it in a lot of places here are that overall, for our population, it's not accurate. The population we're interested in has cross-reactivity with the BCG vaccine and with non-tuberculous mycobacterium. That means when we place a skin test and they've had the BCG vaccine already, they can get a positive result quite often, even though they don't have TB. It's just because of the introduction of the BCG pathogens with the vaccine. It takes several days to get a result from the TST, 2 or 3 days. The result is subjective. That is, somebody's reading on a measuring stick, and that's quite imprecise. There's poor compliance. Many studies over here show that 20 to 40% do not show up to have their test read on time. We know that there's poor training compliance, at least in the United States. People are supposed to be trained every year on how to place the PPD correctly in the forearm, and that doesn't happen. There's actually supposed to be a control placed on the other arm, but I don't know, in my life, I've never even seen someone place a control, but that is part of the protocol. And then finally, because our electronic health records can't track TST, there's no place where it does it accurately. It ends up being written on paper, and then we can't follow those people or audit them or find them, and the results become inaccurate and fraught with error. So the TST actually came along before the automobile in the US, and I think we've moved well beyond that. So where I worked at the Department of Veterans Affairs, we eliminated the skin test in 2009. That was 15 years ago. This is a little bit more intimidating of a slide. You may have seen it. Again, I'll just go through it briefly because you probably know this information. But on the upper left in the yellow, you'll see the Mycobacterium tuberculosis, that's our test of it, our bug of interest. And then those words ESAT6 and CFP10, those are the tuberculosis specific antigens that are in the blood tests, in the IGRAs. They're in the quantiferon. So the two yellow columns to the left are representing whether or not you'll get a positive test on quantiferon. And then on the right, you see the skin test. So to test for tuberculosis, you'll see that both the interferon gamma and the TST should become positive. But if we look down the column of TST, you see that it keeps being positive in situations where it's not representing tuberculosis. So for people who got the BCG vaccine, all these different strains were introduced into their body and their immune system took them up. Their immune system remembers them. So later, when you give a skin test, there's cross-reactivity with all of those different variants that would make the test positive, but does not mean your patient has tuberculosis. Similarly, on the right, the environment is full of mycobacterium that are different strains that are non-pathogenic. And again, the skin test will cross-react with these non-pathogenic mycobacterium to produce a positive skin test that does not represent tuberculosis infection. So we're not moving so far away from the TST for it to be strange. You are all familiar with this test already. It looks very much like the skin test, but just turned sideways. So if we look at the skin test and we look at the bump on the skin, and then the measuring tape that we use to measure how much reactivity there's been, if we could just dive down under the skin and look underneath, we would actually see that that wheel is being caused by all sorts of immune response elements, including interferon gamma. So we are measuring interferon gamma with this measuring tape on the skin, but of course it's inaccurate and difficult to do with different skin types. So instead, the modernization of the test is the IGRA, where you're now taking that same interferon gamma that was causing a wheal in the skin and just measuring it accurately on a machine, quantifying the immune response and giving us a numeric value that says, that accurately measures how much immune response people are having to those very TB specific antigens. So just going from a bump in the skin where the measurement was difficult to do to a quantified measurement of the interferon gamma in blood. They're not really different if you look at it that way. Don't worry, we're not going through this slide. This is just something for you to look back at later so that it's simple. But I wanted to emphasize that the quantiferon gold plus test, the IGRA, is highly specific and not affected by the BCG vaccine. And most of your clientele will have had the BCG. So why does specificity matter? Well, here's a nice little math study where we can look at 100,000 individuals. And if we look at just the specificity and we look at the skin test on the left, we see the specificity is 59%. What does that mean when you test 100,000 people? That means you get about 14,000 false positive results. Those are all people who could go on to have unnecessary chest x-rays, unnecessary medical exams. But more importantly, they become fearful. They're afraid that they have TB when they don't. They're afraid for the safety and welfare of their family. In this country, it can be pretty shameful to have TB. It's seen as sort of other and outside, and people carry that fear and shame with them. And that's not how we want them to come to the US. There's also the Wantai-IGRA that's available, also with lower specificity than the QFT, so that you would get about 5,000 false positive results with that IGRA. But using the quantiferon, we get the best medical results we can, which is only about 2,000 out of 100,000 that would have positive results that would need to be reviewed, and 98,000 true negatives. And this I really want to emphasize to you. This test is very, very, very careful. And if you get a negative result on this test, in the absence of one situation that we'll go over, you can trust your negative. That is, if you have a low p-test probability that your patient has TB, you can trust the negative. if you already believed before you did the test, they're unlikely to have TB. They don't have symptoms, they don't have a background of exposure, and you get a negative, trust it and move on. Okay, so how are you going to do that? How do we do that? Two really great options. You can fill the lithium heparin tube or the sodium heparin tube, so a simple green top with 4 to 5 mLs of blood. I'll go over that, 5 to 6, and send that single green top tube to the laboratory. Boss, done. Or you can use the TB specific tubes that QuantiFERON supplies that are super cool, and I'll explain those to you, and draw just 1 ml into each of those, shake the tubes, I'll explain it to you, and send them to the laboratory. So that's the workflow on the phlebotomy end. Here they are again. So here's a lithium heparin tube or a sodium heparin tube on the left. We need 5 mLs in this single tube so that it can be aliquoted into the other tubes. So the max on the tube is about 6. You can pull 5, but don't go below that. Again, this is just drawing whole blood. And this is really the preferred method in many ways in pediatrics, because in switching the tube, sometimes the parents get scared. If they're little babies, like 1-year-old and older, sometimes you could blow a vein. So it's a lot nicer in some cases when you can to do the single tube in pediatrics, but either way is acceptable and both are just as reliable. So you either draw it into the single tube and then the laboratory will transfer it into the 4 tubes, or you can draw it right into the 4 tubes yourself. So what do these tubes look like up close? They have a nice black band above that gel that you see on the bottom, and they have a vacuum on them. So to draw the 1 ml in, it'll stop around that black band. It's possible to overfill, and it's certainly possible to underfill. So keep an eye on that line and make sure that it's between 0.8 and 1.2 ml that come into each tube. These tubes are coated on the walls. They're specialty tubes. They cannot be substituted for any other tube. And just of note, we have a lot of different tubes available. If you live at very high altitude, talk to your representatives because we do have special tubes for you because the vacuum is affected at altitude. And there's that black band. Okay. This is what makes this test really special. And this is what made me really fall in love with it over a decade ago when I first learned it. It is unique in the world. It is fascinating. So look closely now. If you look closely at these tubes, now we have newer tubes where it's not as obvious, but on this tube, you can look real closely and you can see the coating in the tube. Each of these tubes is coated with something special that we'll talk about, so that when you draw blood into the tube, it's really necessary to take that whole blood and rotate those tubes, just like my hand is doing now. Flip, flop, flip, flop, flip, flop, flip, flop, about 10 times, okay? Or grabbing all 4 at once and rotating them. That's because we want to expose the whole blood to the walls of the tube immediately. Now, they're not going to clot because of the heparin, but this is amazing. The assay, the interferon gamma release, is happening inside the tube. It's the only test in the world that I am aware of where the assay actually happens right in your hand in the tubes, not in the laboratory. Once you rotate the whole blood and expose it to what's on the walls of the tubes, the whole blood interacts with the TB-specific antigens or the other contents, and interferon gamma is released. So the blood says, oh, I've seen TB before. I know my memory T cells remember you. I'm going to release this army and I'm going to send this army to fight off this tuberculosis. And that's all happening right in your hands, right in the tubes. Then you send the tubes to the lab and they do the very specific measurement of the interferon gamma. And I think when you understand that, you'll understand that watching your phlebotomists in your team and making sure that that shaking and that rotating happens is critical. Because if the blood just sits on the bottom of the tube on top of that gel, it's not interacting with the key parts of the assay. Okay, this is easy. Collect the blood. It needs to be incubated. It gets centrifuged in the lab. And then there's a couple different detection methods that are used for pulling out that interferon gamma. It could be a manual ELISA, which is enzyme-linked immunoassay. It could be an automated ELISA, or it could be a chemiluminescence. There's multiple ways to measure that interferon gamma. Then the company provides formulas on the different machines for the data analysis, and you will get results. Okay, deep diving now into, oh good, we're a little bit ahead of time. I hope I didn't talk too quickly. So everyone who needs a breath and a stretch, take it here, because we're going to really study the tubes. This understanding of the tubes is the understanding of the test, and it's the understanding of everything that you're doing for the patient and that you're doing for the United States. So this is really great. The QuantiFERON TB Gold Plus has 4 tubes. Again, you can draw into one tube, and then they're going to be separated into the 4, but you're still going to get results, I hope, on all of these tubes, and this will help you understand how to read them. The gray top tube is the nil. It's a negative control. We know that every test that's done in a laboratory has a control, right? That control should be negative. It says that my test is working correctly. Inside of this tube, basically just heparin. So what the tube is doing when you shake it and expose the whole blood to the walls is you're measuring the amount of interferon gamma that's in the person's background in their blood. So I sniffle a little bit in the mornings. Maybe I have a little bit of a cold. I might have a little bit of circulating interferon gamma that would come up in the blood. It would be a measurement. Let's say that measurement is 1. So I have 1 of interferon gamma. That 1 would later be subtracted from the amount in the other tubes because that's the background. So that's the precision this test offers. So you've got a nil tube, and that's a negative control, making sure that you're starting at a baseline of 0 and making sure that the test is working correctly. What's cool about this IGRA is that it's taking into account people born in other countries. Of course, it's intended for them, and making sure that they have a robust immune system. So the mitogen tube is the positive control. It's coated with phytohemagglutinin, which is a slurry that comes from kidney beans. And the way I colloquially say that, the way I say that more commonly, is it's sort of like having a garbage can on the walls of the tubes. It is very immunogenic. It is intended to stimulate that whole blood and make sure that it releases interferon gamma. Because what the company wanted to do was make certain that it never missed a case of TB. And so if tuberculosis is happening in places where people are malnourished, where they're very elderly, where they have comorbid infections like active HIV or active TB, their immune system might be very suppressed, and maybe they wouldn't be able to mount a response to the TB antigen tubes. So they added a positive control. That positive control, that P, that positive control should give you a positive result, and it's the control on the patient, P for patient. So that's the control that says my patient has a good immune system or my tube is working correctly, and so I have a positive immune response there. Now the special tubes in the middle, the TB1 and the TB2, have those very TB-specific antigens that we talked about before on the TST slide. They are called ESAT6 and CFP10. They exist only in the MTB complex and actually in Mycobacterium tuberculosis itself, and they don't exist in the contents of the BCG vaccine. So they're specific to Mycobacterium tuberculosis. When you take that blood and you expose it to the walls of the tube, the CD4 T cell response will generate interferon gamma, and that is what we will measure. On the TB2 tube, which is newer and again was made for countries where there's a higher burden of tuberculosis, those TB-specific antigens are just slightly longer and different than the peptides that are in the TB1 tube, so that they stimulate both the CD4 and the CD8 T cells. And the goal here was primarily that there would be earlier detection of TB infection, so newer exposures would be detected quicker. So in your countries, you might see that the TB2 tube, because it has both these long chains and these short chains, has a slightly higher value than the TB1. In the United States, because the exposure is often so long ago to TB, it's often back when they were born, we find that the TB1 and TB2 tubes match almost perfectly. Okay, so I remember this slide. I hope that makes sense. A negative control, a positive control. And then 2 TB antigen tubes, because here comes the pop quiz. All right, ready? What do we think when this nil tube comes back with a low value? Are we happy? Is that what we want? It's the negative control, so it should just be measuring the background interferon gamma. So yes, a low nil tube result is what we want. What do we think of a high mitogen result? A high mitogen result is what we want. And this is the way I look at the test. And this is what I would recommend, that you start by looking at your 2 controls. My negative control is low. My positive control is high. My tubes are good. My patient has a strong immune system. Now I'm going to look at the results in the TB antigen tubes. Oh, they're both negative. So if both of those are very low, the patient didn't recognize the TB antigens, they didn't mount an immune response to them, the result you get back from the lab is negative. Similarly, you have a next patient, and this patient tells you that their coughing uncle lives with them and that they think they've been exposed to TB. Sure enough, you get a good negative control back, it's low. You get a good mitogen back, it's high. Now you're ready to take your look at the TB antigen tubes, and they're both positive. The result you get back from the laboratory is positive. Your pre-test probability that that person had TB was already there. This looks like the positive result is reliable, and you believe it and you move on. The negative test, your pre-test probability was, this is a 30-year-old, who's lived in a rural area, not around much TB, never really traveled. I think they're going to be negative, and sure enough, they are. What's really important about this slide, and what I want you to take away from this test is actually pretty easy. I don't want you to think this is confusing. I want you to think this is easy. You understand it. Negative control, positive control, results in the middle. Over 90% of the time, this is what you're going to get. Now, I don't have obviously every one of your countries is different. Your situations are different. So I can't give you a straight up number. But we know what the indeterminate rate is, and we know when you occasionally get a false positive or a false negative that we'll talk about. But more than 90% of the time, you're going to get 2 negatives or you're going to get 2 positives, and it's going to comport with what you expected. Wash your hands, report the test, and then we'll talk about educating and treatment. So again, I'm going to always emphasize the first general rule of IGRA interpretation. There's the slide that I showed you, right, which is the result, but then there's your job as the physician to do the interpretation. So the diagnosis of Mycobacterium infection and decisions about their medical management should not be based on an IGRA or a TST alone, but should include consideration of the epidemiologic and medical history and other clinical information. That's just to say, you're smarter than the test. The test is amazing. I think it's one of the best things that ever happened to tuberculosis, but you're the best of all at knowing your patient and putting all the information together. So your clinical judgment wins. Now let's look at a new slide of QFT results. This is what we call the caution principle. Again, I tell you that the company does not want to miss any positives, and they don't want there to be a chance that the test didn't result correctly. So now you've got some results back, and the nil tube is low. That's good, right? Yeah. Negative, nil, nothing. That's what we want. The mitogen tube testing the immune system of the patient is positive for the patient. That's high, that's good. Now we have two different results. We have one tube reading positive and one tube reading negative. Well, what happens with that? Because of the cautionary principle of the company, and because we never want to miss a possible infection, the result that you will get is positive. So if you only look at the result and you don't look at the quantitative value on the tubes, the individual readings on the tubes, you will not have the same amount of information as a clinician that you would have if you look at the whole assay. Now you see that there's a positive and a negative. What are you going to do with that? This is your clinical judgment. By and large, we think you should accept the positive because we always want to be careful. But if you're really sure that you don't think that this is the right result, you might choose to do the test again. Again, a positive result is a positive result and you can go with it. But if you're really feeling like it's an anomaly, maybe the whole family's negative, and this is the 11-year-old, good immune system, one of the tubes is just slightly over the cutoff point, just barely positive, you might use your clinical judgment differently in that case. Another interpretation, low nil, that's good. High mitogen, that's good. TB antigen, now the case is reversed and the TB2 is positive, but the TB1 is negative. Again, the result that you're going to get from the laboratory is positive, and that's fine. You can send it forward as a positive, but if you're feeling that it's not accurate, you can keep working on using your clinical judgment to retest that patient and look at it again. Again, this is going to be rare, okay? This is, well, not rare. It's maybe 4%, 2%, some small number of the tubes that you get back are going to have discordancy that will cause you concern. Now, let's say you have this discordant result and you know that there was a recent exposure. If this is post-exposure, this is positive. Take the positive and believe it. If you have any reason to believe that the discordant result is picking up a distant positive, of course, you're just going to go with that result. Okay, we're getting to the end of the quiz. Uh-oh, now your nil tube is too high. What are you going to do with this result? This is a non-positive, non-negative result, and this will happen at the most 2% of the time. It happened to me over the decades at about 0.5, so a half of 1%. If the nil tube is high, and it doesn't matter what the rest of the tubes have. It doesn't matter because the result that you're going to get is indeterminate. This is very rare. This is a non-positive, non-negative result. Or if your mitogen tube, your control on your patient is very low, you're also going to end up with an indeterminate rate, an indeterminate. That's the result you'll see, indeterminate. I want you to know and understand why this happens, even though it happens rarely. Remember that the mitogen tube, well, let's start with the nil. The nil, the negative control, you shouldn't have a lot of background interferon gamma. And if you have so much interferon gamma in your negative control tube that it tops it out, once you expose blood to the TB antigens, there won't be any more room to release more measurable interferon gamma. So if the nil tube is too high, we can't measure it anymore. And you're just sorry, and you'll get an indeterminate result because it'll just say we can't run the test in this case. Why would that happen clinically? Maybe you have your patient has excessive background interferon gamma because they've got another infection at the time. They're really sick, their immune system's working and it's already released all the interferon gamma it can. In the very rare case, the patient will have heterophile antibody. Again, quite rare. I don't know if I've even seen it once in my 15 years. I know Dr. Vlad has seen it, but rare. And the other real reason is incorrect sample handling. So let's think about this. The mitogen tube should have a very high value. The nil tube should have a very low value. If the tubes get switched in the lab, if the caps get switched in the lab, you could see the opposite happen. you could get your results and have a super high negative nil tube, and you could have a super low positive control or mitogen tube. So you can see that, well, this one, they seem to have been switched. And you can call the laboratory and talk about that, or you could resend the test if that's what you suspect happened. But I'm teaching you the values on the tube so you can have that clinical acumen to know what you expect. The high nil indeterminates are so rare that in a clinical study, they make up less than 1/4 of 1% of all the subjects. Let's go to the positive control tube. Why would the mitogen tube be low? Because the person might have a weakened immune system, right? Lots of reasons for that. They have HIV with a low CD4 count. They're not on antiretrovirals already. Those patients, very immune compromised. They might not have been able to mount an immune response significant enough to trigger the positive control. That also means they wouldn't be able to fight off their TB. Maybe they have a really new infection, like less than 8 weeks. The TB2 tube should pick that up, but if it's that new and the T cells haven't had a chance to work, then the mitogen tube might. I'm sorry, I want to correct that. Leave that one out. They could have other overwhelming infections like viral, fungal, and bacterial. They could be on immunosuppressive medications, particularly a lot of the rheumatoid arthritis medications, the monoclonals that we see out there now. They could have overwhelming TB, malnutrition, or be at the extremes of the age groups, newborn or elderly. And as I mentioned, there could be technical issues for the positive control tube not getting a high enough result. And that one of those technical issues could be, as I mentioned, that they didn't shake the tube and expose the blood to the walls. Another technical issue could be that PHA that's coating the tube, it's a little bit heat sensitive. And so if the tubes got too hot at some point, it can degrade the PHA on the walls so that there isn't a response. And so there can be pre-analytic reasons that you get a low mitogen. There can be biologic reasons. Understanding this is just really important to you as a clinician. The most common reason is that the tubes were not shaken correctly and the whole blood didn't get exposed to the walls of the mitogen tube. Well, if you have a really low mitogen result, like I'm showing you on this slide, you have a low nil, so that's good. But now you also have a low mitogen. What's going to happen to the test? Well, I told you that it was going to be indeterminate. The one exception to it being indeterminate is if either of those TB antigen tubes actually does respond, if they have just enough of an immune system to mount a response to one of these TB antigen tubes, you will get a positive result. The tubes, the test will always be careful. It will always be cautionary. And when there's ever a positive result in one of the TB antigen tubes that's readable, we will send the positive result forward for you to look at. That's how we take care of our patients. So we are down near the end, which is perfect timing. So let's put it together in a couple of slides. Sometimes you'll hear about a false negative, and we know that there's a black box warning on the IGRAs for active tuberculosis. You're the specialist in active tuberculosis. I expect you've seen it 1,000 times more than I have. So I'm not going to teach you about active tuberculosis here. We're just talking about latent TB and what happens in the US. But on this test, you can get false negatives, and that number, of course, varies by population, with people who have overwhelming tuberculosis. And the reason for that is that these tests, as we've been talking about the whole time, they're measuring the cell-mediated immunity. And that's the key diagnostic test for latent TB, that memory, that cell-mediated immunity that happened over time. Well, if there's so much active disease that the cell-mediated immunity is busy taking care of the TB, and the immune system has now been depleted such that it doesn't mount enough of a response on the test, active TB will be missed, and the test will result negative. Okay, so cell-mediated immunity for this test is key for latent TB, but it's not as reliable for active TB. As the disease goes up, the immune system goes down. And when the immune system is down enough, this test won't pick it up and you can get a false negative. So again, use your clinical judgment. If they're coughing, they have hemoptysis, they have positive TB in the family, you know they've been exposed. You don't even need this test. You're going to move on and you're going to do your tests for active TB. So just a few key points. IGRAs can be supportive tests for active TB diagnosis. A positive result can help you with your pretest probability, especially if they're smear negative or the disease is extrapulmonary. So smear negative disease, extrapulmonary disease, here are some places where a positive result really can help you. However, a negative result does not rule out active tuberculosis, since active TB itself is immunosuppressive, especially when the disease is advanced. Indeterminate results we talked about should be 2% of less than all results that you get. They can be clinically meaningful though, because when you look at the test results, they could be informing you about the patient's immune status. And they could be informing you that there's a technical issue at your laboratory that caused an indeterminate and you have an action item to take. Always examine the quantitative values, especially if you get a result on the end that was unexpected. I'm not going to go through this very long. Again, this is a slide I just want you to have to be able to use for later. It's sort of like a cheat sheet. On the left, you get a negative result. You're not surprised because there was no known exposure to active TB. They have no symptoms, and your TB1 and your TB2 tube agree. Boom, most of your results. The other huge portion of the results you'll get is that your patients came in and they have known or probable exposure to active TB before they saw you. Maybe they have a little bit of symptomatology. And their TB1 and TB 90% of all the results you're going to get are those two on the left. Every now and then you could get an indeterminate. And I'm going over this again and again because I don't think you're going to hear it another time. With the indeterminate, there's been no known exposure to active TB. They have no symptoms. Their mitogen tube is low. You're like, how can that be? Their TB1 tube and TB2 tubes are negative. The result that you get back is indeterminate. If you get an indeterminate result back, you probably just want to retest it, or you want to check and see if you can really find the cause. But always, 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 the answer is clinical judgment. If active TB is suspected, disregard the IGRA. Go ahead and pursue a chest X-ray or a culture or other workup, a NAT. Or if the result is contrary to your clinical judgment in either direction, disregard the IGRA and pursue your clinical workup as you see fit. You are the experts. Last thing, latent TB must be treated if active TB is to be prevented. So circling back to the United States, you're sending your people here. What will happen to them when they get here? If you can initiate treatment in your own country, please do it. That would be wonderful. Once they get here and they get seen in the United States by our public health officers, they will probably be offered one of these short course therapies. So we don't use the 6 or 9 months of daily INH for treatment here anymore. We mostly use these short course therapies, all recommended by the CDC. The one that's most common right now is called 3HP. It's one on the top. It's 3 months of once a week isoniazid and rifapentine. That means there's 12 total doses of medications being taken, just 12 to treat latent TB. Now, the truth is it's kind of a handful of medications because it's weight-based and people here tend to weigh more than people in other countries. So it's a handful once a week. So for that reason, a lot of people choose the second one down, which is 4 months of rifampin. It's once a day for 4 months. Some people find that easier to tolerate rather than the bolus of pills and easier to remember. It's also a little easier in this country to get access to the rifampin pill rather than the rifapentine pill. So these short course therapies, on the bottom, I have a reference for you to the New England Journal of Medicine. The 3-HP treatment, the 3 months INH plus rifapentine versus the 9 months of INH for latent TB, and was shown over 10 years ago to have equal efficacy, significantly less toxicity, and significantly greater treatment compliance. So I'd like you, with your positive results patients, to please talk to them about treatment. Let them know that we have short treatments here, that we do want them treated, that it is important to keep their families safe, to keep their households safe, and to keep whatever job their co-employees and their customers safe as well. Latent TB treatment is mild and it does work, as we saw earlier. Sorry, flipping through the slides in the wrong direction. What's happening? Excuse me, something's just happening on the slide deck. Okay, I think we were here. We were at summary. Woohoo! You are a key component of the TB elimination plan for the United States. You are a key component to eliminating TB in the US. QuantiFERON is a highly specific tool for latent TB diagnosis. Review the quantitative TB results, the QFT results. Advanced TB disease is immunosuppressive, so it could cause a false negative or an indeterminate result. But indeterminate results can inform you about the patient's immune status. The vast majority of QFT results that you're going to get are likely to be concord, and that means they are going to agree. They're going to both be positive or they're going to both be negative. But now you know what to do if they don't agree. Your expert clinical judgment overrides any test result. I recommend that you form a relationship with your laboratory colleagues. It's really helpful to be able to call them and ask them if they're seeing a rise in indeterminates or a rise in positives, or to ask them when you see a funny result. It's a really nice relationship and it's a really interesting test to be able to discuss. Treatment is an essential component of latent TB patient care. So please, in your positive patients, mention that. Oh, that was the slide that I missed, which is that this is a handout that I will provide you the website. This is a front and back handout on the short course therapy. You could give this potentially to your positive patients and have them bring it with them to request this 12-day antibiotic treatment. Back to the end of the slide again, treatment is an essential component of latent TB patient care. Reach out to QIAGEN anytime you need us. We're all over the world and there's all sorts of experts ready to help you with tube interpretation or pretest analytics. There's no question too small. There's no time that we won't be there to help. And thank you most of all for caring for our newest Americans. We value them and we value you. Thank you very, very much. And we're going to have time for questions now. I will get this up here and stop sharing. Thank you so much.
Thank you so much, Dr. Thanasi, for insightful presentation full of practical tips on implementing and interpreting IGRA. We also appreciate the attention of the audience and we'll use the remaining time that we have to address your questions. So just a few notes on the questions. Some of you may have access to the chat feature, the Q&A feature that we've enabled, but if you are not on a Teams account, you can also email your questions to info@panelphysician.org in case you are having any issues submitting your questions. And I know a question that has come up that I can just go ahead and answer is when the recording of this presentation and a copy of the presentation will be available, you'll receive an email once the recording has processed at the close of the meeting and you'll be able to access it there. So without further ado, I'm checking in and we don't have any questions here aside from questions about the presentation and recording, but encourage you all to submit any questions you have on the implementation of IGRA or any of the content which Dr. Thanasi has presented. And I'll kick us off with one question for you, Dr. Thanasi. It's where the rubber meets the road, and you have so much great experience in witnessing the new implementation of IGRA in different settings here in the US. What are some of the barriers that you have observed in the implementation of IGRA, maybe in settings where it was a new technology that was being adopted? And what are some of the solutions maybe that you've seen to overcoming those challenges?
Well, thank you for that difficult question to start us off with. I love it. I want to also just again thank the audience. Thank you all. I hope that you not having questions doesn't mean that you're confused. I hope it means that you are satisfied. Don't be shy to ask anything, because I know that it feels a little confusing at first, but I hope that I made it really simple. What are the challenges people overcome? It's really the initiation by the clinicians. Once the clinicians understand how important specificity is and the incredible value of IGRAs to the patient, and they become the advocates, anything can be overcome. ELISA is an old technology, enzyme-linked immunoassays. Almost all laboratories can do either a manual ELISA or an automated ELISA. Sometimes people are fearful about the cost. The cost of IGRAs has been shown in many, 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 many papers all around the world to end up being less expensive than the skin test, because there's such a high false positive rate with the skin test that then people have to, not only do they have to start off with 2 different visits, which is costly both to them and their family time and their work time, but also to the clinic. But it's also expensive to do chest x-rays on thousands of people who don't need it, to do follow-up consultation, to to spend all the time doing a new history and a new survey once you get results that aren't reliable. So people worry about the cost of the IGRA sometimes, and there are as many of you as there are, as many countries as there are, you're going to have different costs associated with it. But most public health pricing in most places around the world have very reasonable prices, and it's worth it to do one-stop shopping, get her done, get the right answer the first time. It's almost always going to be exactly spot on, boss, done, move them on their way. So I think that QIAGEN honestly has such an amazing sales team and spends so much time being really careful that everybody's well trained, that other than that hurdle of people getting started, once they get started, I find that there've been very few barriers.
Thank you for that, Dr. Thanasi. We have another question. If an IGRA is positive, will it always be positive?
Oh, that's an outstanding question. Early on, when the quantiferon first came out, there were some really nice studies done of people who were treated, and then IGRAs were used afterwards and looked to see whether or not they reverted, which is what I think this person is sort of getting at. There's 2 different implications behind this question. One is, can somebody's own immune system clear TB and it becomes negative over time? Another would be like, does your immune system just forget TB? So you get a negative over time. And a third would be, can you be treated for TB and then your test becomes negative? In all of those situations, the short answer is the IGRA should remain positive. We believe that it does because the memory T cells live inside us for much of our life. So that memory T cell, especially with any repeated stimulation, should remain positive. But I was starting to say that there were studies early on of people who were tested after they were treated. And those studies found that about 40% of people became negative after the first positive after treatment. However, they might not have been true positives in the first place. They might have been people, it was the older generation of test, and they might have been people who just sort of bumped over that positive line, had one little sort of positive, and they would have tested negative next time. What I think is really important for everybody to remember, that's a brilliant question, is that this is an indirect assay. You're not actually seeing tuberculosis on a microscope slide, right? This is an indirect view. It's the interferon gamma releasing interferon gamma. So I'm making it more confusing than it needs to be. So my apologies, because I could talk about this forever. It's a brilliant question. Um, Chances are the positive will stay positive over time. We do know that there's some natural clearance. We know that people who have been exposed can transiently be positive and then be negative later on. But generally, their positive should remain positive over time if it was a true positive in the first place. That's probably a better way of saying it.
I
It's
have
confusing.
another, thank you for that. And I have another question. This is from Adamu Sampson, Dr. Adamu. Thank you for a great presentation. Please, my question is, can switching of the mitogen tubes cover between two patient samples, e.g. during spinning, cause an indeterminate result? So
Okay,
switch,
so
and I see Dr. Vlad is coming on, maybe
yeah, Dr. Vlad is a
Dr. Vlad.
laboratory specialist. Feel
Uh,
free to chime in. I'll drink coffee.
Thank you so much. Yeah, that's why I felt like probably it's a good time for me also to be here, to turn my camera on. The question is, what is exactly meant by switching? I don't really get the question exactly. So if you can just repeat it, Alex, probably for me.
So he says, can switching of the mitogen tubes over between two patient samples, e.g. during spinning, cause an indeterminate result?
Right. Okay. So maybe it's better to answer the question by email, whatever, because probably our attendee can give some examples. But in general, if we obviously mix up two different specimens, then it may just cause a confusion, and I would not accept these results, right? Because if there are any chances of mixing specimens up or mixing tubes up, right? So that's about pre-analytical. I think it's important here to point out that even if the laboratory and if a clinician see the PDF file, the printout saying that valid ELISA run, it would not account for any pre-analytical errors because valid run only relates to ELISA run rather than tube spinning down or incubation. So if laboratory has any doubts in terms of whether tubes been handled correctly, if any mix-up occurred or mislabeling occurred, is the best practice is always just to re-bleed the patient or retest specimens and let's say tube if of course we can ensure that specimens haven't been mixed up in the first place. That's the best answer I can give right now, but probably we can follow up by emails if necessary. Thank you.
Thank you, Dr. Vlad. And this is sort of a follow-up to if an IGRA test is positive, if it will always be positive. We always get a lot of questions about indeterminate results as well. If an indeterminate result, if there is an indeterminate result, will it always be indeterminate or is it worth retesting at any point?
Wendy, do you want to take it? I don't know from a clinical standpoint about retesting indeterminate results.
Exactly. Alexandra, just read that to me one more time so I make sure I get the question correct.
So similar to the question about the positive result is if it's always positive for an indeterminate result, is that always indeterminate or is there value in retesting at some point for indeterminate results?
So that's an absolutely terrific question. There's great value in retesting it. I like to give this example that I was an emergency physician for 20 years, and on probably every single shift, I would get a potassium back that was like 8.6, which here in America is incompatible with life on our measurement. And then I'd go in the room and the person's on the cell phone. So I knew right away that test result isn't right. I just resent it. I would do that with an indeterminate. I would resend it. You don't have time, to do too much. If you got a second indeterminate result, at that point, I think you're really convinced that there's something going on with that person's immune system, or something going on with that lab. And that's where the phone call to the laboratory is, hey, are you seeing a whole lot of indeterminate results? It may be that we need to send somebody out there from QIAGEN to do more pre-analytical training. When the mitogen, my first test that I ever had as director of our program was indeterminate. And I was a little worried about my immune system. And ever since then, they've been fine. So every now and then, occasionally, an indeterminate will happen. You can drill down and try to figure out why, or you can just repeat it the first time on a new sample of blood, which Dr. Vlad will agree is very important. You don't need to retest the same sample. If your laboratory is good, the results should be the same. So a new sample of blood, retest it. In America, when they do that, over 97% of the repeats are negative. And that's because I taught you that if one of those TB antigen tubes had come back positive, we would have resulted out the positive. So very, very often that indeterminate is going to be a negative, but it's worth getting that result, especially in the situation you're in where that result matters so much for their immigration. Thank you.
Thank you for that, Dr. Thanasi. We have another question. For laboratories with high volumes in the QFT process, when do you recommend to stop the process and have the opportunity to process the samples later on? So this is a setting where there are hundreds of samples daily that they'll be processing. And I think the question that they're asking is, at what point would you cut off, I guess, the collection of those samples?
Maybe I'm happy to take that, but obviously we also have another QIAGEN representative, a call from marketing who can help here. I think what we really should consider here is what kind of testing, what kind of laboratory equipment you have in your possession, and whether it's automated, semi-automated, or manual processing, because this would have a dramatic effect on what you are doing, right? So in terms of stopping, I think you can, and there are recommendations in our IFU and guidelines, then of course you can keep specimens. And again, I just won't be repeating here because everything is in instruction for use and manuals and guidelines. And I think our marketing and sales will be more than happy to help and provide training here. But generally speaking, it will depend on what kind of equipment you have in your possession. If you have an automated equipment, of course, you can process a lot more compared to semi-automated or manual. I think the best scenario here is just to contact a QIAGEN or commercial partner representative and jointly work, and collectively they would be able to work with you and provide you with the best possible advice.
Thank you so much, Dr. Vlad. Another question that's come in, other than technical error or human error, is there a chance for a false positive? Aside from technical or human error?
Maybe because it's laboratory side, I can take it as well. Well, of course, because it depends on what kind of error we are talking about. Again, if we talk about mixing up specimens and just mislabeling, right, or processing someone else's specimens labeled incorrectly, then of course it may lead to results being false positive. The same applies if we accidentally mix up tubes and test mitogen tube, for example, in place of TB1 or TB2 tube. Again, it may result in in the result being recorded as false positive. That's why we always empathize an importance of GLP, good laboratory practice principles, and of course laboratories being accredited locally by local authorized bodies. There's always a good practice to work only with accredited laboratories, who demonstrate good laboratory practice and adhering to certain laboratory standards. So in short, unfortunately, yes, human errors can lead to false positive results, and the best way of avoiding it is adopting principles of GLP, good laboratory practice. Thank you.
Alexandra, thank you so much, Dr. Vlad. And I just say that because I always stumble over Nikolaevsky.
Vlad,
but,
yeah. That's much better.
but we must
I
be
went with
Dr.
it.
Vlad. Alexandra, was part of that question, are there false positives other than laboratory based? The last question?
The submitter of the question does not specify any particular scenario or situation. Just says other than technical or human error if there is a chance for false positive.
Right. So other than technical or human error. So as Dr. Vlad says, the technical and human error are by far, the most suspect. But the other answer to your question is yes. And I don't want to get too far in the weeds, and you can always contact me about this. In a very low burden setting where you have a low risk of disease and a low pretest probability of disease, low prevalence of disease, a low risk person, in that case, because this is measuring the interferon gamma and it's not directly seeing TB, one could have a result where the interferon gamma is just over that cutoff point. So the cutoff point was made very, very low. And this is a really key point for everybody who's been brave enough to stay on. When the US FDA cleared it here, and I assume the European was quite similar, they wanted us not to miss any cases of TB. And there's always a trade-off, right? So the amount of interferon gamma allowable to be called negative is very, very low. It's 0.34 on a scale that goes up to 10. At 0.35 or 0.36, that test will have a qualitative result that says positive. But again, it's not a direct look at tuberculosis. You're not directly seeing it. It's a line that was drawn where the government said, we want to be really cautious and we want to know that that negative is stone cold negative, that we are not missing TB. And when you set that bar so low that you never miss a case, that means you're going to overread some other ones. So yes, look at the quantitative values. It's just math. I see Dr. Vlad nodding, and I appreciate that because we're both in medical affairs. We want you to trust the test. We want you to understand that we believe in the positives. But when you get into the nuances of medical direction, that's what we're here for. So look at the values. That's why I spent the time teaching you those. If your tubes are discordant, one's just over the line, one's just below the line. If your results are really, really low, 0.4, 0.5, 0.7, something that's sort of right down there within 1 or 2 standard deviations of 0.35, and your pre-test clinical judgment says they don't have TB, just send it again. Because the other math principle is that the test will regress to the mean. The second test will be more reliable than the first. That's like game theory, and we could talk about that another time. But it's a terrific question, and I hope everybody listened and understands that just over the cutoff point is a number. It doesn't mean that you have visualized tuberculosis in that person. It's more probabilistic. Thank you.
Thank you
for the excellent question.
Thank you Yes, and thank you so much, Dr. Thanasi, Dr. Vlad, for your time. To all of the participants for joining today. We're here at the end of time that we have today. We hope that this webinar was useful to you all, and we had great attendance, and also want to encourage you to send us questions that you have to info@panelphysician.org if anything remained unanswered, or you're looking for other types of information. We're so grateful to our collaborative partners at QIAGEN for presenting this webinar in conjunction with us here at IPA. And I'm seeing lots of messages in the chat as well. Thank you for this wonderful presentation. Just a little housekeeping note, the recording will be sent to you as soon as the meeting closes. It will take some time to process, and you'll receive a recording of today's meeting that you can refer back to. So with that, I'd like to close the meeting today's webinar. Thank you again to Dr. Thanasi, to Dr. Vlad, to all of our partners at QIAGEN, and to all of you for joining and for your engagement today. Thank you all. Have a wonderful day.
Thank you so much. Thank you. Have a good day.
Thank you.